Good morning, everyone. Thank you, KSOS, for giving me an opportunity for this presentation. So today I'll be talking about OCTA and diabetic retinopathy and retinal vascular diseases. So basically, OCTA is not a diagnostic tool for diabetic retinopathy, but it helps in the supporting our diagnosis. So as you know, we have three vascular complexes. One is the superficial vascular complex, which is seen between the nerve fiber layer and the ganglion cell IPL layer. Then we have the intermediate complex, which is seen between the ganglion cell IPL layer and the outer and the inner plexiform layer, and the inner nuclear layer and the inner plexiform layer, and the deep vascular complex, which is seen between the inner nuclear layer and the outer plexiform layer. So OCTA is based on the ability to image flow in retinal and choroidal vasculature. So we have three patterns of abnormalities. One is the abnormal presence of the flow, and this is basically neovascularization, and which can be either in the retina or in the choroid. And this is actually a choroidal neovascularization, which will be dealt in the later talks. Then we have anomalous vessel geometry, that is, it can be either dilated tortuous vessels. And here you can see the most common condition is central retinal vein occlusion. And this is the patient with central retinal vein occlusion showing anomalous vessel geometry. And the next is absence of flow. Absence of flow can be either due to non-perfusion or capillary dropout. Here you can see an area of non-perfusion within which you find an area of abnormal blood flow. So this is a patient with peripheral vein occlusion with neovascularization, and which typically occurs at the junction of the perfused and the non-perfused vessel. Now, OCT in diabetic retinopathy, it's helpfoal because it might be seen even before we can see it clinically. For example, the increased foveal avascular zone, decreased parafoveal vascular density, and the lower foveal density at the deep capillary plexus. These indicate high risk of diabetic retinopathy. So in diabetic retinopathy, we look for macular ischemia as well as neovascularization. So this is a patient of showing the fundus fluorescein angiogram. Here you can see there is an increased foveal avascular zone. The same thing with OCTA is also picked up. You can see an increased foveal avascular zone along with the capillary dropout, which shows macular ischemia. This is another photo showing the foveal avascular zone, increased foveal avascular zone in fundus fluorescein angiography, and the same thing is seen in the OCT angiogram. And the microaneurysms which are seen in the fundus fluorescein angiography cannot be picked up in OCT angiography because OCT angiography doesn't show leakage, but only the blood cell movement within the capillaries. Now let's see few case examples. This was a case one, a patient who came to the OPD with vision of 6/9 in both the eyes. It was a mild non-proliferative diabetic retinopathy. And as you can see in the OCT thickness, there is no significant macular thickening. But the OCTA shows increased foveal avascular zone, not only in the superficial capillary plexus, but also in the deep capillary plexus. So the macular ischemia was responsible for the subnormal vision in this patient. Now, this is another patient which was diagnosed as severe NPDR, but the OCT angiography over the disc shows neovascularization, and hence the diagnosis changed from severe NPDR to PDR. Now, this was another patient, a one-eyed patient with a right eye vitreous hemorrhage, and the left eye showed moderate NPDR. And this is the montage picture. But the OCT angiography shows peripheral capillary dropout along with the neovascularization from the disc. So the diagnosis changed from moderate NPDR to proliferative diabetic retinopathy. So nowadays in the market there is wide field OCT angiography, which is about 16 by 16 millimeter, in which with a single shot of OCT angiogram we get the peripheral capillary dropouts, and even the peripheral neovascularization could be seen. Now coming on to retinal vascular disorders, OCTA is an excellent tool for imaging areas of ischemia and the non-perfusion. It also helps in detection of neovascularization. And the ability to image the deep capillary plexus is one advantage of OCTA over fundus fluorescein angiography. Now this is a patient with central retinal artery occlusion, and the fundus angiogram and the fluorescein angiogram shows the macular ischemia, and the same thing is picked up in OCTA. There's another patient with branch retinal arterial occlusion, and as you can see here, there is a hyperreflective lesion in the OCT in the superior macula. And the same thing when you look at the superficial capillary plexus, you can see there is a hypofluorescence. There is a hypoperfusion in this area in the superficial capillary plexus, and also in the deep capillary plexus, you can see there is a hypoperfusion. So all these can be picked up in OCT angiography. This is the picture of branch retinal vein occlusion. This is the fundus photo, and the fluorescein angiogram you can show peripheral capillary dropouts, and the same thing is picked up in the OCT angiography. So it is an advantage. The OCT angiogram is an advantage of with compared to the fundus fluorescent angiography, because we can see almost the same picture. Now this is a montage picture in which it was a lasered branch retinal vein occlusion, and the capillary dropout areas can be seen in OCTA. Now this is a picture of peripheral vascular lesion in which the capillary dropout areas are seen in the superficial vascular complex. But if you see in the deep vascular complex, it is seen much more. So what we see as the perfused, whatever remains perfused in superficial vascular plexus will not be perfused in deep vascular plexus. So basically we have to look not only the superficial vascular plexus but also in the deep vascular plexus, because over there we can see much more changes. Now this is a OCT angiogram of a patient which has come for subsequent follow-up. Here you can see this was a fresh branch retinal vein occlusion. Here you can see the OCT is same for both the eyes. There was not much of a macular thickness, but on subsequent follow-up of this patient, you can see there was development of collaterals in subsequent visit. So this was showing a compensatory vein occlusion. Now in case of non-ischemic CRVO, here you can see there is a macular ischemia with capillary dropouts in the superficial as well as in the deep capillary plexus. So hence OCTA is helpful in diagnosing both in diabetic retinopathy and retinal vascular disease. Thank you.